This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hi there. Welcome to It's Not In Your Head. I'm Justine Feidelson here with Dr. Dan Bates. We're really excited and grateful to have you with us for our first episode today. Today, we're going to get into why did we call this podcast It's Not In Your Head, and we're going to give you a bit of background on myself as well as my co-host, Dr. Dan Bates.
Thanks, Juz. That was actually like the best intro you've done so far.
I know, Dan laughs at me at all my intros because I come in too hot with too much excitement, but that's because we've been working on this thing for how long, Dan? Like 6 months now behind the scenes?
6 months now.
And it's been so long that we almost had to circle back to why exactly did we call this thing It's Not In Your Head? Because in the process of working through why does chronic pain make it feel as though to so many patients their symptoms are in their head, it almost seems absurd to suggest that at this point. Yet it is pretty common, and in a lot of places and in a lot of people's experiences, unfortunately, how they've been made to feel either intentionally or unintentionally by their pain physician and other people that, to be fair, they've come across in the years of struggling with oftentimes extreme, hard to explain, confusing symptoms, right?
Correct. So from my side of things, we've moved through a couple of different names for this podcast. We settled on It's Not On Your Head because it seems to resonate best with my patients. I think that like when I see the majority of my patients, they've seen many, many other people before they get to see me. And at some point in time, someone's tried to explain the mechanisms of chronic pain. And so at this point in time, those explanations include two major things. Number one, that the pain driver is now gone, that you don't have a pain driver anymore. And then two, that you have a misinterpretation of a signal. Now, if I'm a patient, the way I hear that is that you're telling me I'm imagining my pain. Right. And I think that, from a clinician perspective, as soon as I make the patient feel like I'm telling them they're imagining their pain, that's me telling them I don't believe them, and that means I've lost them. And as soon as I've lost them, I can't do my job, which is to actually help them. And so over many years, I developed ways to explain pain that get away from referencing changes inside the brain, although these days, like I can without making people feel like they're imagining things, because it's just physiological changes. And it's not in your head. Let's just be really blunt about it. It's not in your head. And the explanations that we use or that have been used previously, the pain driver is gone. It's a misinterpretation of a signal. Within the current definitions of what is chronic pain, those things no longer make logical sense. Right. And so we'll take you through why that's the case, and we'll give you a whole stack of different options to think about pain and hopefully over time treat pain effectively.
Thanks a lot, Dan. And when dealing with patients who have been in the system for a lot of years, one of the most important things is to help them feel capable and help them feel like they do impact their pain. And when you empower patients to actually take more responsibility and ownership and be able to, because they understand better how pain works, and although it's a difficult responsibility to have to take that ownership over it, it gives you so many more options and takes away a lot of the helplessness and that feeling of defeat that creeps into a lot of people when they hear over and over again, not necessarily you're crazy in those blunt of a terms, but it makes you feel that way, like Dr. Dan talked about. So I'll get into a little bit of my background and personal history, and Dan will share some of his too. Before we get into that, we'll talk a little bit about how we actually connected and crossed paths to begin with. Originally, my spinal cord stimulator surgeon, Dr. Chakravarthy, was a good friend of Dr. Dan Bates's, right? Where did you guys meet, Dan?
We originally met in Florida when we were both doing this program called the INiYH program. So the INiYH program was something that was targeted at developing neuromodulators around the world. So nice. Essentially 12 of us that were in this group. And we did a bunch of different education programs throughout the US and Europe throughout a year. And during that period of time, Chris and I became really good mates.
Yeah. And then Krish and I had been working together for a number of years treating my complex regional pain syndrome. And over the course of that time, I had been building my own business and working with other complex regional pain syndrome patients, but hadn't shared as much about it or my own work with Krish until he started developing this conference, a patient facing conference called Empower You, and really a foundation that is his brainchild to be able to better impact access and education and help patients, right, understand the different components of their pain that pain intervention can treat versus what aspects of their pain, like we'll explore further on this podcast too, they impact. And after speaking on the patient panel at that inaugural conference last year, that's where Dan and I met. He was on the faculty for Empower You, which Krish pulled him into. I'm sure you didn't have much of a choice. Dan, Krish gets really excited and passionate about the missions that he's pursuing. And I'm a lot like that as well. And so once he kind of explained what he was thinking, it really, really spoke to me and was in alignment with what changes I saw needed to be made in the chronic pain space and helping patients better understand what's going on in their bodies and why is something that Dan is really passionate about too. And you can tell in the way that he communicates and empathizes with patients and the challenging experience that they have, as well as physicians have trying to treat complex, chronic, hard to sometimes understand or explain diseases and diagnoses, especially from patients.
Yeah. When I met Jazz, I remember saying to Krish, Justine was there as a patient in that setting, really wasn't there as a clinician. And I remember saying to Krish, you got to like bring her as a clinician, not as a patient. Like she's got tons of stuff. And at that point in time, he'd gone, yeah, I want to do it. Like I want to set up a podcast. I went, okay. He goes, I want you to do the podcast. I went, okay, cool. He goes, I want Jazz to do it too. I went, okay, cool, let's do it with Jazz. And then, well, here we are now. And it was sort of like, yeah, let's just get going. No problems, except that's not the way it's worked. And there's been, 6 months of working through how we're going to structure and develop and talk about this so that it's not a disjointed mess.
It's a lot to try to bite off, right? Even individual diseases like EDS are called, the books come out on them and they're called disjointed. Try tackling all of chronic pain, sensitization, central sensitization really, which is a big piece of most people who have complex long-term chronic pain. It's hard to avoid because you get this positive feedback loop, right? Of whatever your original, as we'll get into, nociceptive driver is. Well, if that's not addressed, then you start to get spinal cord, central nervous system involvement, and it really amplifies the crap out of your symptoms. And that's that piece that gets chalked up to it's in your head too often for patients when it's not. We just have a really poor understanding of how these pieces are interconnected because we also put everyone in specialties, right? That's how we tackle and approach medicine, not just in the US, but a lot of places, which makes it even harder to see the patterns and it really muddies the water. And then you do end up with this very disjointed view on actually the same pattern or process, we'll argue, happening in a lot of different systems and in what we actually identify as a lot of different diagnoses, but we don't think they are. So before you get into all the fun stuff around what types of pain are we dealing with as far as nociceptive, neuropathic, or central sensitization, nociplastic pain. Like I said, we'll just share a little bit more about our individual backgrounds, and then we'll get into all of that. So I am a pain coach, patient, as Dan touched on too, and a movement professional. So I began my chronic pain saga, unfortunately, long before CRPS. I had a brain injury in 2011, about 5 months after I graduated college. So I spent the next 9 years during what would otherwise be, right, a pretty pivotal decade of people's lives, recovering on, like, the stat I had was over 100 medications, might be over 100 treatments, but like well over 50 meds, right? And then those types of alternative things, good and bad, that are not medication related. I had a ton of cognitive issues, memory, speech problems. I did outpatient rehab for years on and off, doing speech therapy, working on things that, a lot of the symptoms I chalked up to the brain injury. And then as the years went on, in hindsight, I realized a lot of the symptoms, unfortunately, were also drug side effects. And you see that a lot in the chronic pain population too, where after some point, the toll that the medications take is as much in many ways as the pain you were originally trying to deal with and treat. That's what happened to me trying to manage what are also called cluster headaches, but also called trigeminal neuralgia. And I went all the way up to fentanyl trying to treat that, which is not an effective way, for example, to treat that type of pain. That's not going to help memory, speech, etc. All, while being on other medications for depression, bipolar, anxiety, right? Severe insomnia. When you chalk up sleep debt for years and years, good luck with your cognitive function, right? I talk about it even with people who have other situations and diseases. If a healthy person behaved in those ways, they'd end up so sick so fast, right? Not eating, not sleeping, super stressed, isolated, on a ton of meds. And when you do that with a chronic illness, you have way less of a buffer. You have no room to play with. So unfortunately, I did everything wrong basically over those years because I didn't know better and I didn't have the appropriate knowledge or influences to look at, geez, what of this awful situation can I control instead of trying to outsource every piece of it? Because like I said, I just didn't know better. And in fact, I'd argue that's kind of what we're taught. That's what you do. Have a PT problem, go see a physical therapist, right? Whatever your situation is, you just outsource that component of it. And unfortunately, right, I had undiagnosed HEDS probably this whole time, which was a part of the gastric issues, a part of a lot of these neurological symptoms too that can progress over time. And I just had no ability to deal with that situation. And that's what I was seeing in the chronic pain space as well. I just went through it for a different reason all those years. And then when I developed complex regional pain syndrome, as I started to wean myself off the remaining medications I was on, right? So a lot of those diagnoses weren't even correct or accurate. They just kind of made sense given how messed up I was, but I was a complete, shell of myself. And so it took time with a very different situation to figure out how to approach it. But I did not want to go the route I med before, going medication after medication, right? Thinking the next thing is going to save me. Because you think that, but it's not. There's not an easier, softer way, unfortunately. And at least if you feel like you have support and you have, a collaborative approach and it's not just you alone tackling these things, you can impact your symptoms an enormous amount through things that you as a patient impact. But if you rely completely on the medical system and medical professionals, it makes it really hard for you and it makes it really hard for them. So I early in my CRPS journey, started using movement as a tool to downregulate, desensitize, distract myself from a lot of the really intense symptoms I was dealing with early on. The hardest part for me with CRPS was actually after I had the spinal cord surgery and I was past that implant. And that's when I was like, oh my God, I've exhausted the medical system. I've kind of done everything that they have to offer. And I'm still not even close to, functional or being able to use my leg or having the capacity or tolerance to bear my own weight or to put my leg on the ground. And so I realized if I am going to live another 60 years, there's a long way to go post where am I at now with this? And so that's really where I started then developing my methods and the MARS method, kind of working out how to progress from a movement perspective, as well as recovery, sleep cycle, circadian rhythm, right? Wind down routine, fueling, nutrition, all these things that help manage energy and stress, as well as your mindset and perspective with pain, because that's either going to amplify or help you manage that. And creating a system where I could teach this to other people who had also exhausted everything that they could and were feeling almost as lost and hopeless as when they got their diagnosis to begin with, because then that is a very daunting situation to face. So that's where I created Resilient Warrior Coaching and started to not only do individual design, one-on-one programs for patients, but be able to teach this on a group level and with different master classes and courses so that more pain patients could be exposed to the aspects that are just difficult to either literally implement or communicate about with the limitations of the medical system, right? And how much time physicians have to work on these things. So that's kind of how I ended up getting into what I do and why I'm so passionate about what I do, because I was that person that I work with. And I have seen that when you you can think you can never get better or that you'll never be the way you were, but that's if you do or don't do certain things to a degree. And so if you do all those things, then let's see where you're at. And that's kind of what gets me really excited, and why I think there's an enormous amount of hope for a lot of people with hard to treat conditions that they've been told this is the best we can do for you, because that's not always true.
Yeah. And I think that if you're watching this rather than listening to this, what you'll see is that Justine will implement a bunch of her techniques as she develops more pain while we're chit-chatting. And she'll wriggle and she'll stand up and she'll lay on the floor, and which is all a bunch of different techniques that she utilizes to be able to control pain and get stuff done. And she's impressive at what she does, and I hope you can learn lots from her. From my perspective, so I'm not actually a pain specialist. I'm actually a sports and exercise physician. So in the US, the equivalent of that's like a physiatrist, and in the Europe, the equivalent of that's a sports and exercise physician. And what's happened for me over the years is that when you start off and you've got a small practice, you're building. And so as a result, you're seeing people that injure themselves on the weekend, and they'll see you then on Monday, Tuesday, whatever. Or you'll be looking after teams. I've looked after a bunch of different professional teams. You'll watch the player get injured, and then you'll see them the next day, and away you go. And so what you're doing is you have time within your list to be able to see people, and you're regularly treating acute pain. Over time, though, what happens is that you might be treating young kids to start with. What you end up doing is treating their mums and dads, and they come in with different problems that have been around for much longer. And then you start treating their grandparents, and they start coming in with problems that have been around for longer and longer. And then, what happened for me is some circumstances occurred, and I got booked out like months ahead. And you don't have to be booked out months ahead, but if you're booked out 2-3 weeks ahead, a week ahead, the people can wait and have got chronic pain. And so all of a sudden, my skill base needed to change because my patients have changed. Right. And so, my first change in patients went towards osteoarthritis. And so I then learned how to treat patients with osteoarthritis, particularly in the setting of those 40-year-olds, 45, 50-year-olds that they don't want a joint replacement. No one actually wants to put a joint replacement in.
Right.
And so we need to look at what strategies can we implement to get on top of your pain and delay a joint replacement as long as possible. Then my patients changed again. Then I started seeing more back pain patients. And what I found is that the things that I had developed within the osteoarthritis world, which was the pain pie, and we'll explain that, and I'll go through the pain pie with you at some point. I took the pain pie and I put it into the context of back pain. And within back pain, you then get back pain, neck pain, you start getting more neuropathic pain. And so once again, my skill base changed. My skill base changed in that setting to be doing more diagnostic blocks and a lot of therapeutic procedures. So essentially the majority of the time I do interventions. So I'll be looking to try and identify what's the cause of your pain and then see if we can go on and treat it. As I've been around more, then what's happened is that I've had another morph in my patients. And now, particularly, 12 months ago, nearly 18 months ago, one of my colleagues retired. And he retired, and I live in Melbourne, Australia. And
in case you couldn't tell by the accent.
Yeah, if you couldn't tell.
Maybe not Melbourne, but yeah.
And when he retired, he saw a large number of patients with hypermobile EDS in Melbourne. And when he retired, he just went, "Go see Dan." And I was like, so then I was overrun with the most complicated patients I have ever treated in my life. You name it, like of everything I've done, from times I spent in ICU, from times I spent doing renal medicine, like, oh my God, hypermobile EDS patients are exceptionally complicated.
We are the gift.
Prior to that, sure, I'd had a lot of contact with body part pain, which is also known as nociceptive pain, a lot of contact with neuropathic pain, and then a lot of contact with sensitization, but more within the context of, a body part that's been hurting for a long time or a nerve that's been giving people grief for a long time. Not in the context of a metabolic disorder where you then come in with a large amount of symptoms consistent with what I would think is sensitization and what Justine's already alluded to. And so my patient and my skill base, once again, has changed because I need to be able to match what my patients need. And so over time, that's where, and so now, most of the time, what I do is I look after people with long-term back, neck, and joint pain. My actual business is called Back, Neck, and Joint because that's actually what I look after. And I have a large number of patients that I look after that are hypermobile EDS, complex regional pain syndrome, that are all really difficult. And what's happened and what I've really loved with this relationship with Juz is that her skill base complements my skill base. So I have this, I'm very lucky. I got taught by some amazing clinicians of how to diagnose and then treat certain components of pain. Yeah. What Justine brings to my skill base and from her skill base is how to treat all the things that come about, the sleep disorder, the fatigue, the POTS symptoms, the gastrointestinal symptoms, the bladder symptoms, all that stuff. And together we actually make a pretty good team. And I hope that we'll be able to both deliver both that entire spectrum. So everything from what's wrong, how do you treat it, to also how do you deal with the consequences and manage it along the way as you're getting better. So hopefully that's what we'll do for you.
In the next episode of It's Not in Your Head, we're going to get into multiple better ways to think about pain rather than just the nervous system as a prediction generating machine or the patient is misinterpreting it. For example, with the pain pie, as well as pain is a sound system, which will help you understand how we can then work through what Dan and I are calling the pain puzzle and break out all the different aspects and components of your presentation. So thanks a lot for listening to this episode, and we'll see you next time.
Thanks, Charles. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.